So I think, as Hilary said at the start, I have CLL, and I've been part of the team on FLAIR since it was about halfway through, and I've been part of the team on static since right at the beginning. And what I'm talking about at the moment, really, what we're talking about now, is that involvement in the static trial. And I think, just like many other things in healthcare, the kind of the role of patients and members of the public is something that's developing and evolving all the time. So, I mean, I guess the first question is, what is patient and public involvement in research? And a definition that's used quite often is that patients or other people with relevant experience contribute to how the research is designed and conducted, and also, really importantly, how these results are shared and what they mean for people with those conditions and their families. And a way of sort of putting that in a nutshell is public involvement in research means research that is done sort of with and by the public. It's not to, about, or for them. So it really is about working as equal members of the team. Next slide, please. So why do we want to do this? Why should patients and the public get involved? Well, there's been, I think, over the last 20 to 30 years, there's been a growing body of clear evidence, really, that having patients and members of the public involved actually improves both the quality and the relevance of clinical trials. So I think it was widely expected that the relevance, so it seems really obvious to somebody with CLL that if you involve patients, you're more likely to do research that affects the lives of people with CLL, rather than if you don't include those people. But the other part that I think probably surprised more people was that it also improves the quality of what's done. So how does patient and public involvement do this? But it does help ensure that the research questions are relevant, because if they're not, it's a waste of everybody's time and money. So it's also about, appropriate use of the limited resources that we have for research. It ensures that the trial is designed in a way which is acceptable to those taking part. So you don't ask people to do things that it's just not sensible to do. So you try and get your research done in a way that fits with the cycle of what would happen normally to that person in the NHS. So you don't ask for extra clinic visits unless there's a very good reason. You don't ask them to fill out hundreds of pages of questionnaires, because people largely don't have the time or the energy to do that. A particularly important part of this is having, in order for people to make informed decisions about whether they are interested and willing to take part in research, you need to be able to give them information which is understandable. And I think that's an area where there's been a huge improvement now in most committees that look at the research before it's approved will insist that people with the condition have looked at the information before it's approved. Another really important aspect is making sure that people who do take part have a better experience. I mean, all of this contributes to it, because if they have a better experience, they're more likely to complete the study. And if they don't complete the study, that affects the quality, because you've got missing information at the end. And then absolutely fundamentally, there's better communication of the results to those taking part and the wider community. If you've had people with the condition involved all the way through, they understand it and they understand the questions that their own community has, and they can communicate that. Next slide, please. Thank you. So what did we do in static? As I said, there has been PPI contributing to the design right from the beginning. So there was input in getting the trial funded, writing the early trial documents, and deciding how and when to talk to people about taking part in the trial. Because this is an unusual study, it's talking to people about pausing their treatment. Most cancer trials are about starting new exciting treatments, and this was not. And certainly personally, it can be quite challenging to be told that to even consider that you're going to pause your treatment, and it takes time to think about if you want to take part in a study like this, and you often have lots of questions. So when you approach a person is also important, and it's really important to give them time so they've got time to think about it and talk to people. The PPI has also contributed to how the trial is done. So Hilary and I are both members of the trial management group, which is the group responsible for basically for the day-to-day running of the trial. And it meets every 6 weeks. Pre-COVID, those sorts of meetings used to be face-to-face. They're now all online. But they are very much discussing the day-to-day running of the trial and inputting into that. And we also have a small group of, slightly wider group of for PPI, which is, again, people with CLL that meets probably roughly every 3 months to discuss issues around PPI involvement in more depth, really, and more broadly than is possible in the trial management group meeting. And one of the things that's come out of all of this is that we've developed a website for people taking part or interested in taking part. Next slide, please. And this has just recently gone live. This is the first screenshot. And I'll then hand over to Rhiannon, who will explain this website in more detail and explain its background. Thank you.